Okay, so welcome to the Enhancing Clinical Practice and Outcomes stream of the SNOMED CT Expo 2023. My name is Ian Green. I'm the Customer Relations Lead for Europe and also the Global Clinical Engagement Lead for SNOMED International, and I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. For those online attendees, please use the Q&A button that you'll find at the bottom of your screens. And for the on-site attendees, please use the microphone and I'll wander around and provide the microphone for you. So without further ado, I'd like to introduce to you Elze de Groot from NICTIS in the Netherlands, and she'll be presenting the possibilities or impossibilities of data exchange between nursing terminologies. Elze, please proceed.
Thanks, Ian. I a little bit had a cold from this morning, so don't mind that. We heard a lot about ICMP from the last presentations, but my presentation is about some other terminologies, and that's Omaha and Nanda. Yes. So what am I going to talk about? I'm going to talk about NICTIS, just for the overview about SNOMED implementation advice we had in the Netherlands, our current situation, some analysis we did, and implementation options we have. First about me, who am I? I am Elze de Groot. I'm working at the NRC of the Netherlands. As a terminology expert. I'm not a nurse. My background is medical informatics. NICTIS, the NRC of the Netherlands is part of Terminology Center of the Netherlands, and the Terminology Center is part of NICTIS. So it's just a small part of NICTIS. So what is NICTIS doing? NICTIS is the competence center for digital information management in healthcare. We're doing a lot more than being the NRC of the Netherlands. We also develop information standards. Does it also? No. We develop information standards, and we have a competence center. We also are active in the international exchange data space. The implementation strategy and advice. The government has said in the Netherlands we have to use SNOMED. So in the Netherlands, it's not a question. Do we have to use SNOMED? But how do we use SNOMED? In the last years, it said that nurses should use the same concepts to create unity of meaning. That the correct information has to be at the correct place at the correct time. Availability of data is a hot topic. We have to lower the administrative burden. And agreements with vendor about language and techniques is done. So this is going to be a law. So there's going to be a law that says that availability of data has to be done. There have to be agreements between vendors. So that's a very much improvement. It's good if the law there is there. And the government says SNOMED is the way forward. So that's good, all positive. But the field now says to the government, yeah, it's really nice that you say that we have to use SNOMED, but how are we going to do that? What should we do, and can we do it all together? So they call for regulation, and that's why the government asks us to write a SNOMED implementation advice. In this advice, it will be said how to use SNOMED, when to use SNOMED, where to use SNOMED. And it will be a step-by-step approach. So start small. The implementation advice is now on the consultation phase, and it will be published next month. So I may not say anything about the content yet. when the implementation advice is out and the government will ask the fields to go along, then we expect a lot of work, a lot of people that come to us. Oh, we want reference sets, we want SNOMED. So that's why we why we had an implementation strategy, which means that we are going to ask the content experts, the clinical experts, to maintain their reference sets themselves and maintain the terms themselves. For that, we also have an education platform ready to educate the people to be able to do it themselves. One best practice we now have is that the Pathology Foundation hired a terminology expert. The expert has done our education and now creates the concepts for the pathology themselves. But nursing also has to will be using the implementation advice strategy. And what does this mean for the nursing field? You're doing some work, I think. So, what is the current situation in the nursing field for us? We have nursing homes and hospitals that use OMA system, and we have mainly hospitals and nursing homes that use NANDA. And what is our problem? They can't talk to each other. It's not possible to exchange data between these systems. A little overview of NANDA. NANDA consists of domains, and within these domains are classes, and the classes consists of diagnosis. There are several kinds of nursing diagnosis. There's a problem-focused nursing diagnosis. For them, you can define defining characteristics and related factors. There are health promotion nursing diagnosis. These are the readiness for diagnosis. And there are risk nursing diagnosis for the risk factor, but with the risk factors. And also syndrome, but I won't tell that. I won't use that in my presentation anymore. The OMA system also has a problem classification scheme with 4 domains, and that domain consists of problems or area of concerns. And they have unique signals and symptoms. So I'm just continuing. What else are we having? We also have an information standard e-transfer. And that is defining how to transfer nursing information, patient information. These information standards consist of a data set and clinical building blocks and fire specs. It's the reuse. It's for reusing information established by nurses, cooperation between care professionals and ICT. The Dutch Nursing Society is the owner, and NICTUS is only for the functional and technical maintenance, and is all based on guidelines. For this e-transfer, a SNOMED reference set was created of patient problems. It's already in 2016, some time ago. There's also we are also creating reference sets for observations and interventions, but these are not finished yet. They are added team-based, so around pain, that kind of teams. The process was working groups of nurses from all domains, use cases from practice, and we used SNOMED ICMP mapping that was at that time for selection of terms. If you want to know more, I have a reference with an article that explains all about this. You can also see the reference set in the browser. This is an example of a clinical building blocks. Clinical building blocks are used for the reuse of information. This is an example of wound. It's everyone use the same information of wounds, the same characteristics, the wound type, the wound length. They all exchanged it in the same way. Another example is the problem clinical building block. And in this clinical building block, the reference set of patient problems is used with the problem name code list. We also did a mapping more than 5 years ago from SNOMED to NANDA and OMA system. Actually, only the reference set of patient problems was mapped to NANDA and OMA system. That was a one-to-many mapping, but we saw it was only one way, only SNOMED to NANDA OMA, and we wanted to know if we could exchange data between NANDA and OMA without in a broader perspective. So we did another analysis to be able to find some fit gap analysis. So what did we do? We did a kind of fit gap analysis, and we wanted to analyze if it is possible to exchange data between nursing facilities without losing information. And we looked at the difference in structure, and we looked at the difference in terminology. What process did we use? We selected the top 50 of used diagnoses as well as in NANDA as in Omaha. And we select teams based on the top 50 and the Omaha system area of concerns. And then we looked at now what Omaha codes and what NANDA codes can we select based on these teams, and can we connect them to each other. We also mapped it to SNOMED. So if we have Omaha mapped to SNOMED, NANDA mapped to SNOMED, and look if the same SNOMED code was used. This was a cooperation between the Dutch maintenance organization of OMA and of NANDA and NICTUS and the Dutch Nursing Society in the Netherlands. So we had some starting points. In Omaha, we used the area of concerns, the problems, and the signals and symptoms. And in NANDA, we used the nursing diagnosis with definitions. We did not use the defining characteristics and the related factors. They were out of scope. We only looked to one-to-one mappings, so the without losing information, same meaning. And we also used the nursing health issues reference set to select SNOMED codes if there was doubt what to use. And in Omaha system, when you map to an area of concern, you also have to say what modifier it is, if it is a problem or if it is a risk or a health promotion. And so these are the connections we used. So if you have an area of concern in Omaha system, you can add a modifier, health promotion, potential problem, or actual problem. And these are can be connected somehow in some point to the health promotion diagnosis in NANDA or the risk diagnosis of the problem focused diagnosis. And also a signal and symptom can be connected to a problem focused diagnosis. Some issues we encountered was that the Omaha problem modifiers can only be linked to the area of concern and not to a signal or symptom. So if you have a health promotion diagnosis in NANDA that could be connected to an Omaha signal symptom, then you can't map it because you can't add a modifier of health promotion. The Omaha signal symptoms often contain more concepts. So, for example, wounds and pressure ulcer are in one concept. So you cannot connect it to a wound because the pressure ulcer is also in that concept. And the NANDA chapters are coded, so we couldn't use that. And NANDA diagnosis is really different. The structure of OMA and NANDA is really different from each other. So it's really hard sometimes to map on the same level. Some examples. Self-mutilation in OMA and the self-mutilation in NANDA can be connected. Here we have an apprehension and undefined fear in Omaha. That's in the same concept, so we couldn't map it to an anxiety in NANDA. And here we have a sleep and rest pattern with an extra modifier of health promotion and actual problem. We could map it in some way to NANDA. So these are the results. You can see in around the SNOMED CT with 12,000 findings. The reference set of patient problems consists all of SNOMED findings. The NANDA and OMA system also can be mapped to SNOMED for like 70–80%. So that's quite good. But if you want to map it together, you can see that the overlap is only 18 concepts that are the same. Yeah, what are the implementation options for the Netherlands if we look at these analyses? What do we want? Where do we want to go? We want to use clinical building blocks, structured data exchange, comparable data, and we want to use a uniform list of nursing problems and interventions. That's not where we are now. What we could do, we could use SNOMED as interface terminology and try to replace the nursing classifications all by SNOMED. That would be a big change for applications that use the nursing classifications. And we don't have a showcase yet of SNOMED implementation in the Netherlands. But I now have one in Norway. So what are the advantages? Now everyone would use the same terms and data, so we have comparable data. It's aligned with the clinical building blocks and aligned with other domains that use SNOMED. We could also use SNOMED as an interface terminology for only the problems and interventions with a mapping to the classifications. In this way, we can at least exchange problems and interventions, and systems can use NANDA and OMA for the other things that are in these classifications. That would be work for maintaining mappings. And for the systems, they have to be able to store problems and interventions that are not in NANDA and OMA. But we use the same terms with definitions aligned with other domains and clinical building blocks, and NANDA OMA can still be used. And the last option I can see is use SNOMED as a reference terminology. So maps OMA to SNOMED, map NANDA to SNOMED. But we just saw in the analysis that that will lead to a lot of information loss. We have to maintain mappings. Yeah, they have to maintain their mappings by themselves because we were not going to do it. But there's no alignment with other domains. But the advantage is that the systems and applications have less work and there's nothing to change. So a little wrap up. I think using SNOMED doesn't have to mean all other terminology classifications aren't necessary, but we have to look at how can we use it together without losing a lot of information. The situation we now is not ideal, so I think we have to go to another solution where we can lower the administrative burden, I hope. The future situation is unclear. We have to be decided what we should do. Especially the nursing association together with the hospitals, we will facilitate. But I am curious if there are other countries that also use OMA and NANDA and how they deal with these problems. And if there are nursing SNOMED implementations in use, other than Norway. So that was my presentation. Thank you for your attention.
So thank you. So thank you, Els, and my apologies for the sound interruptions, if nothing else, and also my apologies to those online. So as a reminder, if you want to ask questions, you're in the room, I'll give you the microphone. If you're online, pop them in the QA box and I'll keep an eye on it. Over to you.
Thank you for a great presentation and going over what work you've done to try to reconcile, to make things a little more complex. Would you be able to comment whether nurses in the Netherlands utilize ICF?
There's one hospital in the Netherlands that use ICF. We also have a mapping from the patient problems to ICF as well. Yes, but because it's only one hospital, I had it out of scope.
Yes, I'm Marte from the Norwegian NRC. Great presentation. I remember being there where you are now. We didn't have the Omaha to complicate things, but we did go from NANDA to ICNP. And for as more of a tip than a question is to try to work with the nurses and get them to forget the words.
Yes.
And go into the concepts. What's the idea? What's the action? What's the problem? And then you find the equivalent one in SNOMED CT or ICNP in SNOMED, rather than try to find the words that matches from NANDA and probably from Omaha as well.
Yeah, that's what we did with the SNOMED reference set indeed with the patient support.
Then it sounds like you're ahead. So yeah. Thank you very much for a great presentation.
Other questions? Don't all rush at once.
Not a question, but a comment. I'd like to invite you and everyone who's online, Erica and I, who are the co-leads of the nursing clinical reference group of SNOMED. We'd like to invite you to our next meeting, which is November 14th at 2000 UTC. And that includes everyone who's with us online, because I think you're going to bring so much to our discussions. And Erica, I think yeah, she's nodding, so she agrees.
And I'm Cindy Lundberg with Loink now, but past history with SNOMED. I'm happy to hear that you're using the Omaha system. To be honest with you, I'm very happy about that, because we need to start using the nursing terminologies. Have you given any thought to using the perioperative nursing data set by the American operating room nurses?
No,
No,
but I will talk to you.
okay. Sounds like a deal.
Any other questions? Just have a quick check. I don't think we've got any online. Okay. So in which case then, without further ado, I'll conclude this session. So thank you again to Els.